Thank you so much again. It's no redundant to say and express my honor and joy to be here at this OSD inaugural MEOM session, day dedicated to ocular surface disease. So I will be speaking about neurotrophic keratitis, pathophysiology, and targeted therapies. And I will start by saying that a little word of history. It was formerly known as neuroparalytic keratitis, and it's indeed a degenerative corneal disease. That is, the hallmark is decreased or no corneal sensation at all, and this is tied with the cornea losing its trophic nerve-derived support and protective reflexes that is connected with the impairment of trigeminal innervation leading to this situation. And accordingly, there will be epithelial breakdown, healing impairment, corneal ulceration, and at the extreme, melting and perforation and loss of vision. It's a rare disease. It affects in relatively low percentages these entities that we have here in the slide. And a word of remark to ourselves as clinicians for the herpes zoster. So in terms of etiology, most of the cases are associated with herpetic keratitis, burns, long-term use contact lenses, corneal surgery, neuralgia, trigeminal neurology, ablative surgery, so related with its sequela of surgery, and also jaw fracture reduction surgery, a little bit less with space-occupying intracranial masses and systemic diseases, and special cases with syndromes associated with children in the children population. So there's a loss of corneal sensory innervation that will cause three pillars of problems, these three great aspects that will lead to tragic conditions if we don't do anything to prevent or to just coordinate this, is the lack of trophic support. So the nerves provide neurotrophic factors that are by themselves essential to regeneration of the epithelium. Loss of protective reflexes, blink and tear reflex, and also injury sensation can be completely lost. And impaired wound healing, so the epithelium will become more fragile, less adherent, and less able to proliferate under stress, leading to chronic inflammation and persistent defects and ulcers and melting. So this is what the natural story can lead. So symptoms are rare. The hallmark is indeed the lack or decreased corneal sensation that can be measured clinically with a WISP test or Cochet-Bonnet esthesimeter, or even appreciate by confocal microscopy directly the nerves. The symptoms usually are absent despite very severe lesions that we can check at the slit lamp. We can assess, for instance, previous signs and symptoms that can hint for previous herpetic infections, corneal trauma, surgery, burns, topical medications, long use, etc. Diabetes mellitus again. So this is the staging classification by Mackie. So it starts by stage 1 with punctate keratopathy, no epithelial defect, then growing into persistent epithelial defect with no stromal involvement, and in the third stage and last stage, the epithelial, the stroma will be involved, and also a decimator cell can also develop. So management, starting by supportive measures, as we can see here, lubrication, bandage contact lens, tarsorrhaphy, amniotic membrane, and we will start by those more specific, and for cases that are more difficult and challenging to manage, autologous serum. So what happens in the pathology of this entity is that by a series of stages, the cornea will be lacking epithelial tropic factor supplementation, and the serum can be, by its similarity to unstable unstimulated human tears, can provide those epitheliotropic growth factors, as we have here, growth factor, transforming growth factor, etc. And the therapeutic effect of autologous serum has been established since Fox and Subota. So, mechanisms promoting healing, improving sensitivity and sensibility of the cornea, mimics natural tears, has an anti-inflammatory and anti-infective properties, and it's a preservative-free option. So we usually use it for recalcitrant, severe aqueous deficient dry eye disease, slow non-healing recurrent epithelial breakdown after surgery, non-healing corneal epithelial defect, and neuropathic ocular pain. So all very challenging situations. Now we will highlight the possible important entrance of insulin, topical insulin, in these type of cases. There are evidence of case reports and series of very good response in terms of the healing of cornea when we use and have insulin to use topically. Neurotropic keratopathy, post-surgical defects showing faster healing when with adjuncts, for instance, associated with therapeutic lenses, with favorable short-term safety, because we don't have so much experience in terms of duration of time, and limitations are that we need more random clinical trials, and the protocols are still heterogeneous. Mechanisms of action for topical insulin: stimulating epithelial cell proliferation and migration. It's also an anti-apoptotic and cytoprotective element. It reduces inflammation and also reduces oxidative stress, supports corneal nerve regeneration, and restores basement membrane integrity that is completely injured in this case. Formulation: usually this is what has been experienced and is written in the literature. Typically, this dosing 3-4 times a day. Used usually compounded in preservative-free vehicle, and the duration until the closure or regeneration of the epithelial is around weeks. This is what has been described so far. Adverse events are rarely described, just mild discomfort as a possibility, and long-term safety is still unknown. And this is another and the final approach that we can use, and we have already some evidence supporting this type of approach to use in refractory cases of this kind of disease of the cornea. It has no less started to be spoken since 1972, as in the slide, and has a lot of possibility of applications in terms of the causes of the etiology of the neuropathic keratopathy. So there are a lot of possibilities in terms of surgical techniques. Those who are interested have some evidence here. And last but not least, the synergies, the recombinant human nerve growth factor, and all growth factors that have been and are being under investigation can also bring some support. We will not go into this differential diagnosis with this neuropathy, neurotrophic keratopathy, but we will say that it can be vision threatening. In this case, topical insulin is inexpensive, accessible. It's a rational adjunct, and evidence is promising, but still we have some limited information about that, and can also help in the settings that there's limited access, for instance, for autologous serum or neural growth factors. Autologous serum can support corneal healing, and it has encouraging evidence. And if we can have access to it, it's a very important partner in terms of managing these kind of situations. And also a word of underlining the importance of developing current therapy that goes beyond preventing the disease progression, but also improving corneal sensation, for instance, the topical nerve growth factors derivatives, as we have shown earlier. So we need randomized controlled trials. We need some standardization in terms of formulation, stability, and dosing of the agents that, especially those that last agents that I described and shared with you, and long-term safety and the recurrence rates related with this kind of approach. Thank you so much, and I will end here.